us have cute kids and puppies in the background, and so that way we're not listening to them. But know that the meeting is recorded, and most importantly, if you have any questions, just pop onto the chat feature and ask away, and then I'll try to answer all those or as many as we can at the end. Again, my name is Dr. Kacie Culotta. I'm a dentist and lactation counselor. I am the founder of Latched Beginnings, and I have over a decade of supporting families through personalized holistic dental care. My most important adjective I like to share is that I'm a mother of two. I have a 2-year-old named Isla and a 6-year-old named Arlo. And if you've spent any time around me, you'll get to hear stories about both of them. And I'm always telling moms that the best thing we can do is to trust our mom intuition. And often what that looks like is when someone else is telling us everything looks fine, it's just babies are weird or things are going strange, that's just the way it is to trust your intuition. If you feel that something is not going well, then dive into it. And I like to think of Latched Beginnings as that safe place for moms to come to and for families to come to when they're feeling something's off. They might not know exactly what it is, but know that you're in the right place. So this webinar is educational. It's not a diagnosis. And while I am a doctor, I am not your particular doctor over this webinar. So we'll give you some extra ways to reach out, to schedule an appointment, and to get some more information at the end. So what is an oral tie? A tongue tie, the official diagnosis is called ankyloglossia. And what that is just the frenulum, which everybody has, underneath your tongue is restricted. You can also have restricted frenulum in your top lip, your bottom lip, and in your cheeks. And those are what are going to be known as a lip tie or a buccal tie, the ones that are in your cheek. And we know that oral ties can affect so many different facets. When we have infants, the first symptom that we'll see is an issue with feeding. And then often we'll start to see issues with improper digestion because the GI system is not moving correctly. And then as these children develop, we will start seeing some speech abnormalities, maybe some breathing abnormalities, and development specifically of the oral anatomy, a lot to do with the mid-face anatomy as well. And so why do oral ties matter? They matter because your baby needs to be able to move their lip and their tongue freely for effective feeding. Moving the oral anatomy is important not just for infants, but as they grow into children and adults, because proper feeding is intimately linked with proper breathing, and proper breathing is linked to speech and other things that we develop along the way. For infants specific though, what we'll first start to see when they're infants is that poor motor function of the tongue, the poor motor function of the lip can present in a whole different slew of symptoms. And what I try to tell parents is that you do not need to have every symptom on the list to have an oral tie that needs treatment. You do not have to have painful breastfeeding, although sometimes you may. You do not have to have a low supply, but often if the infant is doing an inefficient job at feeding, so not able to fully empty the breast, the mom's supply is a positive feedback loop, and we'll find that, oh, this baby doesn't need that much milk. We don't need to produce that. And so over the course of several weeks, that supply will start to decrease. And inefficient feeds can be at breast or at bottle. Some babies will have excellent feeds at bottles, but very inefficient feeds at the breast. And then long-term, those infant side effects can turn into problems such as speech clarity, oral motor skill issues when they get to transition to solid foods or to a straw cup. We can also start to see jaw, teeth, and airway development abnormalities such as crowded teeth, and even sleep apnea has been listed long-term. I get the question often from families, what are the long-term consequences if we don't treat a tie that's there in an infant? And what I typically will tell a parent is, yes, we know that oral ties can be linked to speech issues as a child grows. Yes, we know that oral ties can be linked to sleep apnea as they grow. And yes, we know that oral ties can be related to crowding and breathing issues as a child grows. But your child is not to the point where they're speaking. They are not to the point where they have teeth. So when we're choosing to either treat an infant for an oral tie or not treat, we really want to be specific on the symptoms that the infant and the family are having right at this moment. And that's going to present mostly as feeding issues. Now, this is not a slide to bash any pediatrician. I always tell families that their pediatrician is doing a phenomenal job keeping your infant alive. Pediatricians love their patients and they do a great job at it. But we know that training on oral ties is not very common at all in medical school and quite honestly, even in dental school. There was a study in 2012 where they had medical students list if they learned about breastfeeding and infant feeding. And out of all the medical schools in the United States, only 51% of medical students received any training or any education on infant feeding. And of those 51%, they only received 3 hours in their entire course of their 4-year training. So it's not that your pediatrician is purposely missing a tie or not knowing the information. It's because they were simply never taught. And dentists don't do much better as an average profession. We learn, about 74% of us learn about oral ties in dental school, but it's still not 100%. And the depth and the quality of that education is going to differ by each dentist's training and each school that they attend. So, okay, if your pediatrician didn't talk to you about oral ties, no worries. I will do it for you and we can learn together. The other reason a pediatrician might miss an oral tie is that they're not going to be set up to do a functional feeding assessment for your infant. They're going to be making sure weight gain is appropriate, that your child has the reflexes, that they are on the marks that they should have for their milestones. And if they're developing correctly, they get a check mark. But you'll know as a parent that there is a big difference between having your child meet a check mark and doing okay and having a child that's thriving. And often the check marks that we're receiving for our infants is weight gain. And weight gain can be a tricky one because infants that are gaining weight appropriately will often be told, oh, that tongue tie is just a minor thing. It's not causing a problem, obviously, because your baby is gaining weight. But when we really dive into that weight gain, we realize, oh, the baby is gaining weight because mom has a amazing abundant oversupply. So this infant doesn't really have to engage with breastfeeding because they just passively latch on and are being fed for themselves. Or when we ask families, which is a little more common, baby's gaining weight, how is that happening? It's because the family is feeding that infant 12, 15 times a day. It is just a constant cycle of feeding their infant. And that's not a sustainable way to feed long-term once that infant is growing. And so that wait and see approach often overlooks those nuances. And what I would prefer, what we look for in an infant-specific oral tie practice is a proactive evaluation. So some common myths, we talked about the first one. If my baby's gaining weight, there's no problem. Of course, your baby might be gaining weight, but we need to look on, are they efficiently eating? Is the tie causing issues with feeding that are overlooked? A second common myth we get is everybody has a frenulum. This frenulum will just stretch out and grow over time. And that's definitely a myth because frenulums are type 1 collagen, which is really similar to the collagen that's within your tendons and joints. It's dense. It's not the same collagen that your muscles are made out of. That's more type 3. And the reason that's nuanced is because the muscles around the frenulum can stretch, they can become less tense. And that's a big part of what a comprehensive approach is that we'll talk about if your child was evaluated. But the frenulum itself will not. So the frenulum will still stay the same. The frenulum still needs action. And of course, it's not a myth that your babies have a frenulum. Every baby does. Every human on earth should have frenulum. And if you don't, then that's something we need to address. But just because you have a frenulum doesn't mean it's normally functioning. So we really need to look into, is the frenulum allowing the tongue to freely move and have coordinated actions? And same for the lip. So babies are very, very smart and we don't give them enough credit. They will learn how to do what they need to do to survive, but they are going to do it with what they have. So, for an infant that does have an oral tie, these infants, instead of using those fine muscles in their tongue, there's 18 tongue muscles, instead of moving those tiny tongue muscles to feed, they're going to start activating the big chomper muscles to be able to compensate. So the child will be able to eat, but instead of eating with the fine muscles, they're going to be these chewing, chomping muscles, and we get a lot of infants that will start to have more head and neck tension because of that. So some hidden signs parents might notice is they might hear gulping sounds, they might hear clicking sounds while they're feeding. Milk often will leak out of the sides of the infant, and that can be at breast or at bottle. Feeds can be very, very long. So oftentimes I'll ask families, what does a feeding look for your child? And they'll say, oh, it might take them 45 minutes to feed at breast, and then they're hungry an hour later. But that same infant, if you give them a bottle where the bottle is passively feeding them, they say, oh, they'll take a bottle down in 5 minutes, no problem. So that's when we know, okay, there's an inefficiency somewhere in the system. These are also going to be babies that may tend to fall asleep mid-feed. And we like to say that these are our babies that are working so hard that a full meal is too tiring to have. So they will stop when they have a snack. They're done feeding. They have just enough calories to keep them going. They're going to fall asleep, but then they're going to be hungry again in just a few hours. Babies that have oral ties tend to be the babies that are more fussy. They have higher gas from that air leaking in from the sides of their mouth. That's called aerophagia-induced reflux. Some moms may have painful breastfeeding, but not all moms will. And that's definitely a subjective finding that we need to talk about with parents because pain is subjective. Every mom is going to feel pain in a different way. Moms that have breastfed for the first time are going to have different sensations than a mom that's fed 5 children at breast. And just because a tongue tie is there doesn't mean that it has to be painful or that it will be. And then, of course, oral tension is going to be a big one. We talked about these infants that they're compensating. They're using the big muscles. And so they're going to have tighter jaws. Their mouths are going to be more likely to open up smaller. They're not going to be able to get these big latches. And that's definitely something that we want to address earlier on because if the muscles are tight, then this infant is not going to have full range of their head and neck. Feeding for infancy, regardless if it's on breast or bottle, really takes a full range of motion. And an infant that's limited to only going to one side or only partially to one side may be more likely that they'll have the tension ongoing and it will start to affect other milestones like rolling. These infants might end up with plagiocephaly, which is flat spots on their head. So this is why wherever you're looking for an oral tie practice, you'll want to make sure that that provider has a comprehensive approach and will connect you to other therapies, such as physical therapy, if your child has a lot of oral tension, um, as part of the plan. Now, we talked about a little bit before about what happens if we don't treat, if we ignore a tongue tie, or not even ignoring, maybe you just didn't know. And what happens? We often find that parents are putting so much more energy into feeding their child. Being a new parent is exhausting, regardless if it's your first child or your 10th. You're not sleeping well. And when the child is not feeding well, then the whole system gets even more difficult. Maternal breastfeeding supply will definitely take a dip at that 2-week mark where you have a stabilization, but also it starts to happen around the 7th and 8th week of mark as well. And this is when we'll start to have families that will say, my supply was great. And then around the 6-week mark, it took a big dive. And we need to look into, is that because the infant isn't an efficient feeder and therefore not creating that supply and the demand? As infants grow, if they have poor oral motor development, that's going to start showing effects both with feeding in solids, but also with speech. We want that tongue to be able to freely touch the palate. When that tongue is at the palate, it's going to help promote the top palate, which is the top jaw, to grow nice and wide. And as a dentist, we love that because we want enough space for all the teeth to come in. But overall, we also need to realize that the palate is the top of the mouth, but it's also the floor of the nose. So a constricted or tiny, narrow palate is going to result in a more constricted nasal opening. And that's something that we definitely are seeing connections to disordered breathing and sleep apnea as these children grow into adults. And then, of course, we just talked about the dental crowding and misalignment. So what does an evaluation look like for an oral tie? And this is going to be an evaluation specific to an infant. The first person that we want to evaluate looks different in everybody's community, right? Everybody's city has different people, different providers that will be helpful. We'll want to look for infant-specific providers. So an infant-specific dentist, an infant-specific ENT, an occupational therapist, or an infant-specific physical therapist. My preference is that every infant, regardless if they are being fed at bottle or at breast, will receive lactation support as their first entry to someone who's evaluating them. And the reason I like that is because there are several issues that can create poor tongue movement, and not all of them are because of a tongue tie. So some of it is position on how you're holding the infant to feed them, regardless of breast or bottle, what bottle you're using, when you're feeding the infant. And seeing a lactation consultant will help you first identify those variables that are affecting feeding that may not be a tongue tie. But if they are, then that's when we'd want to come see me at Latched Beginnings or the infant-specific provider that's in your community. And that provider really needs to take a comprehensive approach. So we're not looking just at the anatomy. We really want to look at the oral reflexes. We want a full feeding function evaluation. So we're going to look at the weighted feed that you received at the lactation support. How many ounces was that infant taking in during an amount of time? And then we want to take a team collaborative approach. And so what that might look like is an infant that has been compensating with this tongue tie. It has the oral tension that we talked about. We might want that infant to see physical therapy or craniosacral or chiropractic first so that we can get the external, the outside oral tension to decrease. So that way, when it's an appropriate time for us to release the oral anatomy and be able to get the tongue moving more, the infant is already so much higher in their trajectory. And that looks different for every infant. Some infants don't need any body work or other support. Some infants will need that support both before a frenectomy and afterwards. So it's never a one size fits all. And then at Latched Beginnings, I only use a gentle CO2 laser for that frenectomy. And I do that for so many different reasons. because we want the instrument that we use to complete the frenectomy to promote the most appropriate healing, the most gentle release possible. It is a huge privilege to be taking care of infants. They are amazing. And it is not lost on me that a lot of these infants, it is their very first car ride when they come to see me. And these are precious, precious children that we want to treat in the most gentle way. So using a CO2 laser allows us to release that anatomy where we're not introducing any heat to the infant, we're not introducing any water to the infant. We are taking the least amount of time to do the most amount of good for them. And so our approach at Latched Beginnings, I know I touched on this, but our approach at Latched Beginnings is we are an all mom team who gets it. And we even now are an almost grandma team with Sheila, who's going to have her first grandbaby soon. We use the advanced light scalpel CO2 laser, like I spoke about. This is going to allow for faster healing, a more gentle release. And my privilege is to have a collaborative approach with trusted local professionals in the community. And this will allow for a whole body wellness approach. I'm not interested in treating families in a quick, one time, one cookie cutter scenario. My interest is making sure that this infant gets the support that they need, both now, but also connecting them if there's another therapy that would benefit that infant. And sometimes infants come to me for oral ties and they don't have an oral tie. I don't treat them, but I can connect them to the physical therapist or to the occupational therapist or the speech therapist that might better suit them. So we're going to guide you both before, during, and after any type of procedure. What I always want families to know is that you're not alone. Many families will come to me feeling that they were dismissed, that their story, they knew something was not going right. They were first-time parents and they had nothing to compare this to, and they were dismissed. But they knew something was going on. So always trust that instinct, and reach out if you know something's just not going right. You don't have to know the name to know that something might not be going as perfectly as it should. So we got some, this is great questions before the webinar that I'd like to share. Remember, no question is too small. If it's an advanced question or if it's specific to your infant, I'm not able to answer those over social media or through email. Those are ones where we'll need you to come in. One of the questions I got was, what is the best age for an infant to be treated? Or what age should we see an infant? And I typically tell families the best time to see an infant for an oral tie evaluation would be between 2 weeks of life till about 7 to 8 weeks of life. And the reason that is we want them to just get used to being alive for the first few days, get the family used to their newest family member, and make sure that they get time to see the lactation consultant before. Usually by that first 2-week mark, the family's gotten into a feeding rhythm, and that's where either those initial red flags have gone down or those red flags have really stayed and we realize, okay, this is an ongoing problem that we need to think about. And the reason that we want the ideal time is before the 7 or 8-week mark is because infants have their suckling reflex, and that suckling reflex helps them drink. But that suckling reflex starts to integrate at around 12 weeks. And no infant is a stopwatch. So sometimes it's 10 weeks, sometimes it's 14 weeks. You'll notice your infant is getting around that time when they start putting their hands to their mouth a lot. They have a lot more saliva than they used to. And that's a normal part of development. But if we need to act on an oral tie, my preference is always to do so before that reflex integrates so that this infant is really able to learn proper tongue motion and coordination, and that be their primary skill set at this point before they get to the next. So that way they've done all their homework before they get to the next milestone. And that being said, yes, I'll absolutely treat infants older than that. We just need to incorporate a approach that will be mindful of where they are at in their development, and then see what's appropriate for them along the way. And for next steps, you can always schedule an assessment. You can call or go to our website to request an appointment. Our website is a great resource for both booking appointments, but also check out all the documents we have and resources. And then give us a follow on Instagram. We like to share lots of free tips, and it will give you a good insight to the culture of the practice and all of our team members. You do not need to figure it out alone. You take your next step, and we can help you there.
Dr. Culotta, I have a quick question for you.
Yes.
One thing that you mentioned in the presentation that I thought was extremely interesting was that only 51% of medical school students or doctors received any type of training in this specific area of care. You being a practitioner and you being one that you work with these infants daily and so hands-on, how important do you think it is um, for parents to know about this, right? Because if it's not something that pediatricians are being taught or, in training, then it's probably not something that's being translated over in as far as knowledge to the patients and to the parents. How important do you feel this is for parents to know this information?
I mean, as a parent myself, vitally important. As a provider, I would say equally as so.
Hmm.
Families, it would be ideal if we talked about oral ties before the infant even was born, that this was something that we discussed that might be a possibility, and that we have resources for you before the baby's even born. Um, and yes, it is shocking that 51% is the top number that medical school students are learning about any type of infant feeding, breastfeeding, bottle, infant development. And um, it's
Yes.
definitely leaves us some room for improvement.
Yeah,
Absolutely.
absolutely. Especially at such a vital stage in the child's life.
Well, thanks everybody. I appreciate you spending your time. Again, reach out if we can help. Have a great day.
Thank you, Dr.
Thank you.
Culotta. You were great.
Thank you.
Thank you.